Welcome, everybody. I'm excited to be able to introduce our guest speaker today. My name is Jeffrey Bloom. I'm the Director of Graduate Education at the Data Science Institute. And we have with us today John Graves, who's an Associate Professor in the Department of Health Policy and Medicine at Vanderbilt University Medical Center. I don't have a nice Data Science Institute screensaver behind me because it's a COVID talk, so I have COVID behind me instead. So we're doing themed backgrounds. And I'm very excited to be able to have John here today. I've known John for a while. He's been on the faculty at Vanderbilt since 2011. He holds a Ph.D. in health policy from Harvard University, and he has undergraduate degrees in economics and English literature. And Dr. Graves and his team and colleagues have been working with the Tennessee Department of Health and the Governor's Unified COVID-19 Command Center to track COVID in Tennessee, to help understand the data that we're collecting, to provide some insights on the pandemic's impact in Tennessee since the very beginning. And that work leveraged his collaborations with his center, which is the Vanderbilt Center for Health Economics Modeling, which was established this year. And his role was, he was an advisor with policymakers and wrote analytic briefs or reports for public dissemination that that you may have seen that were covered in the news and by local and national media. John does research in the development and use of economic and statistical decision analytic methodologies, focusing on understanding the impact of policy changes on access to health services, healthcare spending, and patient health outcomes. And this was not, interestingly enough, this was not John's first entrance into a politically fraught area or a politically fraught health policy debate. In the early 2000s, he was a staffer in a DC think tank, and he provided early analytic support for Governor Mitt Romney's signature 2006 reform, health insurance reform in Massachusetts. And from 2008 to 2010, he was the lead modeler for the White House Office of Health Reform, for health reform related to the Affordable Health, or as the Affordable Health Care Act was being drafted by Congress in the Obama administration. So sorry for bungling the end of that, but I think I did get it out. So it's fantastic to have somebody who's very much at the intersection of data analytics and understanding data and policy and the interplay between those two. And of course, everyone has seen a lot of epidemiologists and statisticians and a lot of people try to understand the pandemic. So it's great to be able to get a little window into what's going on for the people who have been focusing on this and advising our government. And so I'm very excited that you're here today, and a lot of people are looking forward to this talk. And so, John, I will give you the floor.
Excellent. Well, thanks for hosting me. I'm excited to do this. This is a presentation intended for a broad audience, though there's going to be just a tiny bit of formal notation and math scattered throughout. But what I want to do is provide some thoughts on how we think about the role of data in terms of both understanding and guiding our understanding of the pandemic, looking backwards and moving forward. This work is really, I'm just kind of the quarterback of this team, has been the work of a broad array of folks at Vanderbilt and the Department of Health, et cetera. We have put out a series not only of modeling and analytic briefs, but also if you look on our website, you can see all kinds of briefs in terms of things put out by our team of clinicians, epidemiologists, statisticians, et cetera. So I'd encourage you to go to the department website and go through this. There's some valuable information there above and beyond the work that I'll talk about today. This is our team. It's not exhaustive of everybody that's worked with us over the last year or so, but I do want to thank upfront a very large group of people that have provided really important insight and understanding for us and helping us put together what we have. So I will try to monitor the chat to the extent I can. If I ignore your question, or if it seems like I'm ignoring your question, it's just because I haven't had a chance to glance over at it. I'll try to answer what I can throughout, but of course, we'll leave some time at the end for questions as well. Okay, so what I want to do in my talk today is really outline kind of 3 domains or tools for the use of data for understanding and responding to COVID-19. And I want to introduce this with some basic questions, which I'm going to then try to kind of more formalize in my remarks. And the first question that we might be interested in asking is something simple, like what's the incubation period or the time between infection and symptom onset for SARS-CoV-2 or the virus that causes the disease of COVID-19. Another question we might be interested in asking is how many cases or hospitalizations or deaths there will be in Davidson County next month. And a third question that has been at the top of many people's minds is how many COVID-19 cases or hospitalizations, deaths, whatever outcome you're interested in, would there be if Davidson County lifts its mask requirements or other restrictions that have been in place for roughly the last year or so? So fundamentally, the objective of asking this series of questions is different depending on the question. For the first question, or what's the incubation period for SARS-CoV-2, that's really a what is question. It's primarily the domain of biology, science, epidemiology, et cetera. We really want to understand the parameters that are underlying both the infection and virus and also the disease and consequences of the disease in terms of its impact on the health system and the broader economy. The second objective, or the second question, really relates to a different objective, which is a question relating to where we're going. And the final question is a what if question. So we want to know what if there was a different policy environment in place and what would be the impact of that on whatever outcome we're interested in. That first question really relates to a tool of data, of use of data, of what we would call estimation. So we can think of the virus as having some underlying process that generates the outcomes that we observe in the world. And this type of estimation tool is really about understanding our outcome, or whether that's cases or deaths or hospitalizations, as some function of attributes or parameters that govern how the disease is operating in the population. So we're really interested in these kind of beta parameters, and we really want to get that kind of information correct. We want to know what the incubation period is. We want to know what the serial interval or the interval between a primary case and a secondary case. There's all kinds of parameters governing how the virus is operating that we might be interested in. That's, again, fundamentally a what is question. The second question, or where are we going, is fundamentally a question about prediction. And in this case, we're not necessarily interested in the specific parameters and what their value is, but we're interested in some unrealized state of the world or our outcome, whether that's cases, hospitalizations, or deaths, some in the future. So we're really more interested in this Y hat here, which is our predicted guess at where things are going to be in some period of time, next week, next month, etc. And the third tool that I'm going to discuss is the tools of causal inference. And that's really about understanding states of the world, of counterfactual states of the world, or what would our outcomes look like if a policy is in place versus if that policy were no longer in place. And so the kind of overlying thesis that I'm going to present to you, what I'm going to try to convince you of today, is that data is the common thread to all of these questions. But they're different tools that we can draw upon to understand fundamentally different states of the world that we're trying to ask about with this series of questions. And the other thing is that there are not sharp boundaries across these kind of 3 tools that I'm going to discuss. So the structural model of disease progression can be used to aid in prediction of where cases are going in the future. And it could also possibly inform our understanding of causal inferences, or what would happen in a counterfactual state of the world with or without certain things in place. Data science, kind of more generally, is thought of, like the tools of machine learning, et cetera, as informing really fundamentally tools for prediction, that second question. And so the tools that have been developed through data science and machine learning can be applied to these prediction questions and can also aid in estimation of key disease parameters, as we've seen in some of the models, which I'll discuss. And also, depending on the application and how careful you are, you can also use and draw upon these data science methods to help identify causal factors that try to answer that kind of third question, or the what if question of causal inference. Where things get off the rails, in particular with COVID, is when people work backwards from this, in the sense that I work with data, therefore I have the capability to inform our understanding in any of these domains. And so we see this with what I'm calling credentialism, or within the scientific community of people who might be experts in one particular area, whether that's estimation, prediction, or causal inference, trying to get out into another area that they might not be as familiar with. And also amateurism, or people who might, be familiar with data, but really may not have exposure to the methods and tools that I'll discuss that are fundamentally multidisciplinary and require a multidisciplinary approach. And so, what you end up with, both on the scientific side and more on the lay public side, is this kind of belief that, I have my hammer, I'm used to using it, and so everything with COVID looks like a nail to me. And so what I'm going to, what I'm going to offer you today, this is just a cartoon I found kind of funny. It says, this guy's sitting at his computer, honey, come look, I found some information that all the world's top scientists and doctors missed. But fundamentally, COVID-19 is a multidisciplinary challenge. And what I think the debate over COVID-19 loses track of quite frequently is that our objective is to maximize human welfare. And too often we're kind of marginalizing or focusing or isolating on one dimension of policy, whether that's health outcomes or other outcomes. And really what we want to do is maximize human welfare, which means considering an array of things, whether that's health outcomes, economic outcomes, educational outcomes of children, et cetera. So welfare is multidimensional, and there are often trade-offs to optimizing any given dimension. We could, of course, put in place policies that completely eradicate COVID, but those ignore the costs of doing so on other dimensions that are relevant to overall human welfare, whether that is economic output of the business economy, educational output of kids as well. So from my perspective, when I think about how we've been doing our work, it's really to maximize human welfare and not necessarily proclaim exactly what we should be doing, but rather to sift through uncertainty as it comes to us over time and resolves itself through further scientific inquiry, and outline the contours of the decision problems that policymakers are facing. Should I put in place business restrictions? Should we put in place masking requirements? Should we lift them, et cetera? So our approach has been to try to delineate the trade-offs between doing different approaches to approaching the COVID pandemic, and to offer options to policymakers, and not edicts in terms of specifying exactly how we would go through this. We've seen this debate play out in Tennessee and elsewhere with things around masking requirements, business restrictions, et cetera. Our goal fundamentally has been to produce scientifically rigorous analyses, but we're going to try to package this analyses for policymakers and the lay audience. And that has been a particular challenge with COVID, trying to kind of to fit all of these things into one thing that makes sense and is scientifically rigorous. So what are you going to see in the rest of my talk? I've kind of picked out one table from our analytic reports that we put out. I think this was back in June or so, that really kind of summarizes the various challenges in the three domains that I'm going to talk about. So I'll first walk you through this table, and then we're going to come back to this, and it's going to become more apparent what I mean by that. So this table summarizes from the modeling work that we did, the amount of time that we projected to reach 1,000 COVID hospitalizations statewide under different scenarios of both disease severity, which show up in the columns, and the transmission dynamics of COVID, which show up in the rows. So you can see here that we have multiple scenarios on each, and I'm going to describe exactly why we did this here in a second. So you can see in this cell, for example, that if the transmission number, or the R that I'm sure we've all heard about plenty by now, remains at the time is at 1.13, and if indeed the severity of disease was mild, it would take 50 days from the time of this report to reach 1,000 hospitalizations. Okay, so that's the basic structure of this table. And I'm first going to dive into that first domain, or estimation, or these questions about what is and why that's important to informing what we did here. And for that, we're going to concentrate on why we have these two columns. So our approach to modeling the COVID pandemic really drew upon a chassis drawn from the epidemiologic literature. The structure of the model that we put together is based on what's known as a SEER model, or susceptible, exposed, infectious, and recovered. So these are very standard models in epidemiology. They're differential equations, and you solve it for whatever outcome you're interested in, deaths typically, or cases. And we have adapted a standard SEER model in our work to incorporate what was fundamentally the one question that we have been hyper focused on with our work on COVID-19 in Tennessee, which is the burden on the state healthcare system in terms of who's hospitalized with COVID-19. So what we did was take a standard SEER model where you have a susceptible population, some of them become exposed, and then infectious with the virus. And we've adapted it so that we can actually look at dynamics of hospitalizations versus people who would just develop an infection and go on to have some kind of mild disease that doesn't put them in the hospital. If you go back about a year ago, the whole point of flattening the curve was to relieve pressure on the healthcare system. And we have been, in our group, hyper focused on that question because it was fundamentally what should drive policy, not necessarily the number of cases. Deaths, of course, are important, but they're only a proxy for the processes and burden on the healthcare system that would precede the fatalities that we see in the population. So our group has been hyper focused on this. Most of our reports have focused on the hospitalizations as an outcome, and we built out this model specifically to focus on that as the most important thing that we would concentrate on. One of the guiding principles, this is a quote from Frank Harrell, who's a former chair of the biostats department here, is to carefully choose how you spend your degrees of freedom. The degrees of freedom, of course, being what are the moving pieces that you use, the points of data to pin down the specific values of what you are interested in. So if I told you that 2 plus X equals 4, there's 1 degree of freedom in that expression. So you know that X has to equal 2. But if it's X plus Y equals 4, there's any number of combinations of numbers of X and Y that could yield an answer of 4. So you have more moving degrees of freedom in that case. This is the same representation of the model I just showed, but with all of the parameters that are included. So again, this is our estimation of the disease process at any given time as a function of, there's, I think, 8 or 9 total parameters in this model. So what you have to do when you're trying to kind of manage the degrees of freedom that you have is you have to make choices. How much data you have? We had data on cases, deaths, and hospitalizations. That's only 3 data sources, but we have 9 parameters. We have more missing or unknown information than we have data to inform that. And so you have to make choices when you're doing this type of modeling about where your parameter values come from. A lot of them come from the scientific literature. So for example, parameters governing the incubation time of the virus, the serial interval, or the time between successive cases in a chain of transmission, the amount of days between symptom onset to death, the amount of time from a mild case to recovery. These are all kind of indirectly estimated because we're drawing them from the literature, as opposed to using data that we have to estimate them ourselves. There's another set of both parameters and assumptions that you have to do. For example, the amount of time that people spend in the hospital, or the fraction of cases that we're actually detecting via testing in the community. We know for a fact that we're not getting all of the cases. And so you either have to make assumptions or use the data you have as a degree of freedom to estimate what fraction of those cases are we actually observing when we get those numbers every day at 2 o'clock from the Department of Health. So in our representation of COVID in Tennessee, we've kind of drawn these things from either the literature or through consultation with hospital administrators, et cetera, because our projection of the total number of people in a hospital depends on not only the number of people that need to be hospitalized, but also how long they're there, et cetera. And so we've really focused in terms of how we directly estimate parameters in the model on 3 of the parameters in that SEER model that I just showed you. And then there's a floating parameter, which is the number of infections that seeded the epidemic in Tennessee. So R0 you've probably all heard about before. That's the transmission rate, the fatality rate of, or what proportion or fraction of infected individuals will go on to die, and the probability of hospitalization if you are infected. These are things that we are directly estimating with the data we have from the state. And there's this kind of floating parameter that solves the differential equation that underlies this, which is, given the data that we observe in terms of the number of cases, what is consistent in terms of the number of infections that seeded the epidemic in Tennessee. So you can think of these 4 parameters as our kind of degrees of freedom that we're working with, and everything else we've fixed or pinned down from some external source like the literature. So there's a problem here though. And this is a problem that's shared not only by our model, but by everybody doing modeling on COVID-19. I mentioned that we have available data on case counts of positive tests, daily hospitalization counts, and death counts in the state of Tennessee. But we have 4 unknown parameters. So we have 3 sources of data and 4 unknown parameters, which means in statistical terms, that's known as a non-identified set of equations. And so what that means is there's any number of combinations of these 4 parameters that are consistent with the data that we observe in the world, meaning that we can't quite pin down exactly what the values of these are because there's too few degrees of freedom for the amount of unknown parameters in our model. So I've talked about this in the media a bit. I've likened it to like when you put a fitted sheet on your bed and you get 2 corners down and you walk around to the other corner of your bed and all of a sudden you get 1 corner down and the other end of the bed pops off. So fitting a COVID model, especially given the limitations of data and availability of data in particular early on in the pandemic, was kind of like fitting a queen-sized fitted sheet to a king-size bed. You can't quite get everything pinned down. And so there are any number of combinations of parameters that are consistent with the data you observe. And so that's exactly why we took an approach of recognizing that what we produce in any given realization of the model isn't necessarily the true kind of underlying set of parameters that could give rise to the data that we have. So we fit our model to 2 scenarios in terms of the severity of disease of COVID, meaning that in the mild case, the probability of hospitalization, the probability of death was much lower. And what that also meant was that the fraction of cases that we were detecting through testing was much lower. In another scenario, moderate, and we actually had a 3rd scenario, which is severe, that probability of hospitalization, probability of death was much higher. So again, kind of recognizing and being humble about the fact that we can't quite pin down the exact values of the parameters that are governing the data that we see every day. So that what's known as the identification challenge of modeling COVID is exactly why we took an approach of modeling different scenarios in terms of disease severity. And what's really important to take away from that is that when you do that and you model out, when, for example, in this case, we would hit 1,000 hospitalizations, all of our scenarios were pointing in the same direction. And so you can have more confidence in what you are projecting when you have different scenarios based on different assumptions of the underlying disease that are all showing that hospitalizations are rising. And in this case, we would hit it in 50 days versus 40 days. So it's all pointing in the same direction. An alternative approach, many probably have been following Yu Yang's model at COVID-19 projections. He takes a totally different approach to estimation, and that's completely fine. If you look at all the COVID models out there, you will find that all of them address this question of estimation in very different ways. But again, Yu Yang, I think, has done a really nice job because he has kind of embraced this, use your degrees of freedom wisely philosophy in how he has gone about doing his projections. He's doing it not only at the state level, but also at the national level. He only uses one source of data, and he also folds in a machine learning layer and also a similar SEER model to inform estimation of the underlying parameters that are governing, the number of cases that we're seeing, the number of deaths, et cetera. So that's all by way of saying that there are various kind of tools that you can bring to the estimation table. There's not one set of tools that's particularly the best. And so if you look across the various models that are projecting out, and they all seem to be pointing in the same direction, despite using very different estimation underneath the hood, then you can be much more confident in terms of the projections that those models are bringing to the table. And in fact, you can see that some have put together these ensembles where you kind of combine projections across models. And again, I would, very much say that, that's the best way to kind of interrogate the evidence on COVID-19, at least as it's coming out of the projection models. We are just one piece of evidence of that. And so if we are saying something different than 5 other models, then you should discount what we are saying and vice versa. Okay, so the second domain is this question of prediction. So again, at this point, we're not necessarily interested per se in the specific values of parameters that govern the model. We're more interested in the best prediction of where we're going or some unrealized state of the world in the future. And so we're going to come up with a model with prediction that is a function of other parameters. It doesn't necessarily have to be the same parameters. It could be, in our case it was, but it doesn't necessarily have to be. And again, this is the domain of machine learning that has brought a lot to the table in terms of informing COVID-19. You can take all kinds of different data sources. You don't have to be as parsimonious with prediction as you do with estimation. Bringing cellular mobility to the table, all kinds of other data sources. And that's really the domain of prediction, where we're trying to understand this future state of the world as a function of parameters. Now, in our case, we were actually using the same underlying SEER model to project out into the future. And the benefit of that, of using an epidemiologic chassis for doing predictions into the future, is that it combines scientific knowledge or accumulated scientific knowledge on the underlying structure of the process that's generating the outcomes that we see in the world. So with a epidemiologic chassis like a SEER model, you can actually project out the full time trajectory of the epidemic. And so that's the kind of promise that this type of approach brings to the table. Now, the peril we saw as well, because if you don't get that estimation right, if your underlying parameters are wrong, then you're going to end up with different models that project totally different things. And so, of course, we saw this especially early in the pandemic with certain models projecting high numbers of deaths, certain other models projecting low numbers of death, and everything in between. So that's the drawback to using a prediction method that is based on this kind of epidemiologic chassis that is really dependent on that estimation channel being correct. The other approach to do this, which we did not do in our work, but you can see out there in the world, is more of a machine learning chassis. So not necessarily overlaying your projections on top of a SEER type model or another epidemiologic model, but just using the data that's available to make the best projection of where things are going. And so the promise of that is that you can use, let's say, a machine learning approach and whatever data you have available to you to project out, and it's going to trace out over time. That model is going to do a really nice job of tracing out the true underlying case curve here. But of course, the peril of this type of approach is it's very short-sighted. So the half-life of predictions that come out of this is very, very short. So, you can use this type of model to make very, very accurate predictions in the very short term. But, as you get over longer time horizons, your predictions are just going to decay. And so if indeed you're trying to do long-term policy planning like the state was in terms of like where the hospitalization is going to be the greatest, we need to build out, potentially alternative care sites. Knowing what's going to happen in 2 weeks doesn't help inform that decision. So there's a tension between these type of different approaches in terms of where the prediction timeline is in terms of helping to guide policy. So what you can see here in the rows is how we dealt with this, this question of prediction and error in prediction. We came to the table very honest about the fact that we are not oracles. We do not know necessarily where things are going to be in the future. What we can do is use the underlying model to have scenarios for where that transmission number would go. And so that's why you saw in many of our reports that we would have different scenarios. So if the transmission number remains at 1.13, if it rose and if it fell. And so that was our approach to kind of being honest about the fact that we don't have a crystal ball. We can make predictions into the future with our underlying SEER model, but to the extent that the parameters are changing over time or they've been estimated incorrectly, that prediction is going to be off. And so how robust is the conclusion that we're making based on those predictions under different scenarios for where things were going? One really interesting thing that happened, I'd say over the summer, was that we almost jettisoned that SEER model completely. And this was a recognition of the fact that everything was changing with COVID, with new therapeutics coming online, the care protocols in terms of like who was being admitted to the hospital, how long they were staying in the hospital, et cetera. Everything was changing over the course of the pandemic. And what we found, I would say in, let's say midsummer or so, is that initial model that we had put together, we'd spent so much time putting together, was just not doing a great job of projecting into the future. And if you go back through our reports, you'll notice that we almost never referenced our model after, let's say, June or July. And the reason for that is we settled on an even simpler model. What I'm calling here a sufficient statistic for anticipating those short-term hospitalization needs. So by that point, the state was really interested in at a very granular level in terms of knowing where hospitalizations were going to rise so that they could distribute resources into those areas. So that SEER model did, it was very uncertain upfront. It got better over time, but its utility really decayed leading into the summer. And so what we found through our work was that if you just take the COVID case numbers, and we had data on the specific age of the individuals that were testing positive. So we put together this age-adjusted index, and it almost one for one, both at the state level, but more importantly at an underlying state level, like at the county level, could predict out where hospitalizations were heading in about 14 days in the future. So you can see this black line here, which is the hospitalization index, is basically just offset by about 2 weeks from this case mix index. So we took this model that we spent so much time on and basically tabled it because we found that a simpler model was just doing better than we could do with what we had done before. And so you'll see in all of our modeling reports and dissemination, we really just kind of focused on this case mix index, which again kind of speaks back to this point of use your degrees of freedom wisely. Just because you have a bunch of data at your disposal doesn't mean you should create this like Rube Goldberg type model. Use this absolute simplest version of what you need to project out the outcomes that you care about, which in our case was hospitalizations. Okay, so my third domain that I mentioned in those questions are these what if questions. So these are questions that relate to causal inference. And this is a totally different toolbox than prediction. And it falls under the broader estimation umbrella. But these are about understanding different states of the world. We care about what would hospitalizations look like with the policy in place versus without the policy in place. And so the tools of causal inference are really fundamentally what we need to use to do that. It's not necessarily the tools of prediction or some of the tools of estimation. So this is my usual bread and butter. This is what I teach at Vanderbilt. And I want to kind of walk you through how those of us in the social and biomedical sciences who do causal inference work think about these issues, because it's really important, not only for COVID, but in terms of talking about policy more broadly. The inability or unwillingness of people to think in terms of counterfactuals is a huge barrier, I think, not just generally, but especially with COVID. So imagine, the x-axis here is time, and the y-axis is just your outcome of interest. And all that matters is that a lower number is better. So we have a policy change, and here's where our outcome is at the time of policy change. So let's presume that we see the outcome rise up to this level here. So the outcome is higher after the policy change. The vast majority of discourse over COVID has followed this kind of these contours of this type of example, where you have COVID cases rising over time after some policy change was put in place. What's really fundamental, and what is the kind of bread and butter of causal inference, is not to look simply at this pre to post change in the outcome. Just because the outcome did not end up lower does not mean the policy had no effect. You have to think in terms of the counterfactual world of what would this outcome look like had there been no policy in effect. So the tools of causal inference are really about this counterfactual, or estimating the counterfactual, which more formally defined is the outcome that would have happened in an identical parallel world in which everything else was the same, but there was no policy change. So counterfactually, if the outcome would have ended up here, we would have been in a worse state of the world. And so the tools of causal inference are designed to get at this. The gap between these two things is the causal effect of a policy change. In this case, the policy is actually lowered what we would have observed had the policy not been in place. Just because the outcome was not lower does not mean the policy did not have an impact. So the methods that we teach in causal inference rely on assumptions and modeling to yield estimates of this counterfactual. And thinking, as I mentioned earlier, thinking in terms of counterfactuals is absolutely critical for discussing policy around COVID-19. I think probably the most politically fraught of our modeling reports or analytic reports had to do with mask mandates. So let me walk you through the behind the scenes of how we produce the figures that some of you may have seen splashed across the news over the last few months. So the issue in terms of understanding whether or not masking matters is that these masking requirements, or the behavior underlying them, even if it's not driven by policy, is not randomly assigned. And they often come with other things that people are doing. So just because we observe some area having a masking requirement, it's probably the case that that area is doing a lot of other things to reduce case numbers in the community. And in fact, individuals in that community are also doing all kinds of things. So when you're asking a question of like, do mask mandates work? You have to think about a study design. This is not just about looking at data and applying a regression model and looking at the R squared. You have to think about a study design that can uncover that counterfactual or an estimate of what would have happened to our outcome in the absence of this policy in place. And so the way we approached it in our work was to look at the rollout of county-based masking requirements as a natural experiment to evaluate whether or not cases or hospitalizations and deaths were higher or lower in areas that had implemented these requirements. So in an analysis or a study design like this, you have to make assumptions. There's no getting around it. you can use data to test the plausibility of your assumptions, but you can't validate it completely. So the study design that we drew upon for these causal inference analytics, what is known as difference in differences. And I don't have enough time to get through the details of difference in differences, but it is a workhorse evaluation design that we teach in policy evaluation. And what it buys you is an ability to estimate that counterfactual or the outcomes that would have happened in the absence of the policy change. What you need to know about difference in differences as it applies to our analysis on masking is the assumption that we make in a design like this is that the outcome trajectory in later implementing counties, so counties that implemented their masking requirements later, or in non-implementing counties can stand in for the counterfactual. So you look at the non-implementing counties and how did they evolve over time. And you're going to use that as an estimate of the counterfactual for what the actually implementing counties would have seen in the absence of the policy. So the way to test that is to ask the question of, well, let's look at our outcomes before the policy was ever in place. If this assumption is reasonable, we should see that the outcomes are evolving very similarly across these groups over time, meaning that we should see a flat trend in the difference between outcomes between groups. And that's exactly what you see here. So if this type of study design was not working well, before the implementation period, you would not see a flat line. You would see a line, if they were trending differently, you would either see a line with a positive slope or a line with a negative slope. So this type of analysis never showed up in our final reports, but was really kind of underlying our thinking in terms of was what we were doing in terms of evaluating these masking requirements plausible in terms of using this type of study design to look at the difference or the impact of this kind of bundle of policies on outcomes. So this is on the y-axis is the death rate per 100,000 population in non-masking counties versus masking counties. And you can see that that difference was flat leading into the implementation period of the masking requirements in the masking counties. And then after that implementation period, after all of the counties had kind of adopted it, you can see the death outcome kind of take off, meaning that when you see the graph that we put out to the world, the non-masking counties here in red, death outcomes taking off. The early adopting counties, which is in the gray, as soon after the masking requirements were put in place, started to level out. And even additionally, if you look at the later adopting counties, there's a time lag, but then they also start to see those death outcomes decline. So again, this has to do with drawing on the tools of causal inference or a difference in differences design here, and putting in place assumptions and evaluations of whether the assumptions are reasonable in this context. But fundamentally, this type of analysis, as I kind of mentioned earlier, is very, very different from the former two sets of analyses, whether that's estimation or prediction. And so again, kind of coming back to this kind of common theme, which is that all of our work relied on data for sure, but the tools that we're bringing to the table differ. And where people get really mistaken in terms of COVID is in thinking that their expertise in one particular area can be applied across these different domains without thinking about the tools of those domains that you could bring to the table. And that's really why we took an approach in our work of a multidisciplinary approach. I am not expert in, I do causal inference teaching and modeling in my non-COVID life, but we really had to bring other experts to the table to make sure that we weren't doing something ridiculous when we were thinking about either estimation or prediction and things like that. The other lesson that we've learned, which I think, especially with our case mix index and other things, you really have to be humble and flexible in how you're doing modeling with COVID-19. What works one day might not work in a month, just given how fundamentally things have changed over the course of the pandemic. And so you have to be flexible. What would be optimal as a policy last April is also not necessarily what's optimal moving forward. And so we've tried to embrace this lesson and and be flexible in terms of how we approach issues. And this is really going to be the case as we vaccinate large segments of the population. So for example, we're moving into a period of the pandemic where, cases themselves are kind of decoupling from the fundamentally important outcomes, which are hospitalizations and deaths. So, while cases in our case mix index were important for us in terms of predicting out hospitalizations, let's say 6 months ago, they're much less so important in terms of how we're thinking about projecting out hospitalization and deaths moving forward. So you have to be very flexible in terms of what you bring to the table when you're doing this type of work. And the third final thought is to always think in terms of counterfactuals. The lack of counterfactual thinking in COVID has been rife throughout. And so I think if I were like a benevolent dictator and I could teach anything to every single secondary school person or college student, it would be the coursework in terms of thinking about counterfactuals and evaluation and causal inference. And then the final thought, which I didn't get too much of an opportunity to talk about here, is that communication is key. All of the tools that you can bring to the table are pretty complex, or they can be. And packaging it up for a policymaking audience or a lay audience has been a huge challenge for us. And Jake Lowry, who's our communications person in our department, has done a phenomenal job in terms of like taking, us, the pointy-headed academics, and telling us like, well, you've done this great analytic work, but here, nobody's going to understand what you did. And here's how you communicate this either to a policymaker or to a general public. And so with that, I think I will leave it up for questions, or we can talk about things moving forward.
Professor Graves, thank you so much. That was just wonderful. We would like to open it up for questions now. You're welcome to text your question, or go ahead and click on reactions at the very bottom of your meeting controls. Raise your hand, or you can give me a thumbs up, and I will call on you and ask you to unmute yourself so you can ask your question. Yes, Andreas.
Hi, can you hear me?
Yes.
Yes.
Thanks for that. I wanted to ask you a little bit more about the last point that you just made. How do you find that just about the issue of how you communicate to policymakers who don't have any training in the technical aspect of the models, which for someone who is technically trained, that's a very important part of whether they will believe your model and make decisions on it. Do you find that that it's important to explain to policymaker the technical aspect in a way they'll understand, or is the more technical you go, the worse off you are in terms of getting them to accept the model?
So I'm not quite sure. So most of the policymakers we talked to had absolutely no interest in the nitty-gritty details. Some of them do, but being able to explain the underlying thought experiment especially with the causal inference type stuff, being able to intuitively explain why we're doing what we're doing and how we're kind of interrogating the evidence is important. But I would say in large part, for better or worse, the policymakers take you at your word that you've done something scientifically rigorous, which has obvious drawbacks to it, depending on how actually rigorous the work is. So we didn't really have, I can't think of a case where a policymaker actually asked for the underlying details, but it's something, several of our reports had methodological appendices to them. And we've also engaged quite a bit over email with more technically driven people that had questions on the work that we've done. I've worked, can't name how many people I've walked through differences to over email. And I'm always happy to do it. It's one of my favorite things to teach.
And Tom.
I just wanted to follow up on Andreas's question. So when you're talking with policymakers, how do you, what is the best way to get them to not think about, your model says one thing, the model that was presented on Fox News says another thing, the model that their, aunt says another thing. So how, is it merely credentials and you have to trust their credentials, or are there ways of actually being able to, convince them that, at least there's certain models they should take seriously and others that don't really deserve much credence?
So it's funny, actually, the reason we got into this in the first place was because if you remember, the first state level model that was put on COVID-19 was the IHME model out of the University of Washington. And their first estimates for Tennessee were totally off the wall. They were projecting on any given day, they were saying that there was 1,000 COVID patients in Tennessee hospitals today, when we knew we had the data that said, no, there was 100. And so, every time we were just one model, and we were pretty clear with policymakers, especially up front. I mean, I remember a conversation with the state before we put out our first estimates, which got splashed all over the news. We said, our first estimate is going to be all over the place because we have 2 weeks of data on a brand new virus, and it's going to be wrong. And so we'll put out, scenarios kind of outlining the boundaries of where we think things are going. But, our estimates are going to get better over time, but our first pass at this is going to be wrong. Of course, the newspapers picked out the worst case scenario that we modeled out, which we knew would happen. But, at least we could tell the policymakers, don't, what we say on April 15th or April 7th or whatever it was, is going to be different than what we say a week later. So we went from, I think our first modeling report, we projected somewhere around 2,000 patients hospitalized by midsummer. It ended up being about 1,100. So we weren't horrifically off like the IHME model was. But within 2 or 3 weeks, we actually had narrowed that down. It was down to about 300. And actually, in practice, it was about 300. So it took about 2 weeks for us to get it, in the same ballpark. So, but that kind of underscores how we projected the model to policymakers, saying look, first of all, early on, we're going to be wrong. We're going to adjust over time and it's going to get better. And also if you're looking at other models and they're all over the place, then you should have no confidence in any of them. But if all of the models are pointing in the same direction, in terms of magnitude and ballpark, then you can have more confidence because many of the models drew on totally different approaches for estimation, prediction, you name it. So if they're all pointing in the right direction, then you can have a lot more confidence. But don't put all your eggs into one model was basically the message we gave to the state.
Thank you. Other questions? Please feel free to turn on your video and to raise your physical hand if you'd rather do that. Place it in chat or to raise your hand using your reactions. Matthew.
I was wondering, since we've gone from having one strain of virus to having multiple strains of virus that may have different transmission rates, different fatality rates, how does that affect your modeling? How does that add complexity or uncertainty?
Yeah, it's interesting. We haven't done too much on it, to be honest with you, in terms of modeling, but in terms of my thinking on it, I can offer some thoughts. That's the flip side. How people are discussing the variance is in some ways the flip side of the same coin in terms of how they were discussing some of the other policy things like masking mandates. So, again, you have to think in terms of counterfactuals. Just because the variants are more transmissible does not mean that cases are going to rise. The question is, what would we counterfactually have seen in terms of the case numbers and how they evolve over time if there were no variant versus if there are? So my thinking generally has been, as as the total number of susceptible people declines over time, either through acquired immunity because they've gotten infected in the past or through vaccination increasingly, it is not necessarily the case that just because there are variants that cases are going to rise. It could just be that we see a slower decline in cases than we would have otherwise seen. So that's kind of informed, that counterfactual thinking has kind of informed how I've approached the question of variants. And, obviously, if there's a variant that comes out that escapes the vaccination itself and acquired immunity, then in that case, you would expect cases to rise. We don't have evidence on that yet. And so my expectation would be that we, continue to see cases decline, but they might just decline at a slower rate than we would otherwise see.
Thank you. Joshua.
Can y'all hear me?
Yes.
Yep.
So considering a lot of the modeling work was done, and I can only imagine what it was like. I'm just imagining you with politicians and people. As a data people, it's always a difficult struggle communicating. But so a couple questions. Sorry if there's just two. One, have you, obviously the largest kind of wave, Tennessee's pattern, so we had a kind of winter wave. It was like a stair-step pattern that came out, and then, we had our largest impact and kind of braced and, had our peak in hospitalizations, luckily on our way down now. Can you talk about, if you've done this, any sort of retroactive fitting to some of these models, maybe the case mix index, it looks like it performed pretty well when it comes to hospital demand. As far as if there's ways you're going back to say, hey, now that we have a really great amount, whereas early on you were obviously trying to be as preventative and is giving advice and saying, hey, here's what we could see so that we get the right policies in place ahead of time. Have you done any exercises to sort of retroactively fit to test some of your models? And second question is, what were the best data sources that you were getting? It sounds like you guys moved to some age-based related inputs early on, which really helped with the case mix index. But
Yep.
I mean, we were getting stuff from JHU, COVID tracking, Tennessee Department of Health. Like, what were those sources that you were finding were more trustworthy than others early on?
Yeah. So first question on kind of retrospective assessment. We haven't done, what was really challenging is that if you think about the SEER model that I put on my screen, there's 8 parameters in the model, 8 or 9. Each parameter was changing over time. There's some kind of disease specific parameters that might, be more stable. But if you think about a parameter like the probability of hospitalization, that changed dramatically from April to December, in the sense that, early on, they were admitting a lot of people. The bar for admission was very different. As hospitals started to fill up, the bar for admission changed dramatically. And so, doing those kind of retrospective things is difficult because you can get an average sense of how things evolved. But if I really wanted to know what was truly the probability of hospitalization, I would say, well, it changed over time. And so, we haven't done too much of that because we know, now that more people are getting vaccinated, the probability of an infected case getting hospitalized is going to look very different in 4 weeks than it even does today. And so that's part of the reason why we haven't done a lot of that is just because literally everything is changing. And that really kind of speaks to this kind of identification challenge of you can pin it down maybe at any given point in time, but that doesn't necessarily mean that you've pinned it down, for some point in the future. On the second question, so our data sources, we have, our department has an agreement, a longstanding agreement for infectious disease surveillance with the state. So we have what's known as a line list of data that we receive from the state. It's basically a de-identified Excel file, 1 row for every positive case with no identifying information on it. So we had other than their age and their zip code of residence, that's kind of all we knew about them, and their gender. So we used a lot of that, and that helped a lot because some of the publicly available data sources like the COVID trafficking project, you know, what is reported on any given day is very different than the actual case burden on that day. The other thing that was changing over the course of the pandemic was the amount of time that it took the state to like take a test and process it and then report it. At the most efficient times, it was like 3 days. And then over the fall, it rose up to like 10 days. So what was coming out from, you know, the public data sources was a very noisy picture of where the cases were. Whereas the line list of data that we would get from the state had a very specific, like we knew what date the person was tested. So it gave us a much better sense of where the infection burden was on any given day, because we didn't rely on that reporting date.
We're at the top of the hour. Thank you so much, everyone, for attending. We hope that you'll visit the Data Science Institute to find out about additional events we have coming up, including Women in Data Science, which is going to be March 8th, Women in Data Science 2021 for Nashville. Professor Graves, thank you so much for your time, and thank you for a great presentation. Thank you all so much for your questions. We'll have a recording of this, which you can view later and share with others. Thank you again for coming.
Thanks.
That was really terrific. Thank you so much.
Yeah, happy to do it. Thanks for having me.
Yeah, absolutely. Wish we could have a second hour for additional questions because time for much.
Yeah. All right. Thank you.
Have a good night. Bye-bye.